So this is Rhett continuing the ECG overview. I tried to clean this up as best I could, but I missed a little of the red, so sorry about that. But we're actually talking now about the T wave. The T wave, in terms of progression of this depolarization, is the actual repolarization of the ventricle. So they depolarize here. This is where they repolarize. Some things I'll mention about this. If your T wave is inverted, i.e. it dips underneath like that, you could think about coronary ischemia. You can often see it with left ventricular hypertrophy. Basically, it's an idea that something's going on with your left ventricle. But another thing I want to say is that if it's really tall, i.e. you might hear about peak T waves. People represent them like that. Everyone thinks about hyperkalemia. So if you see T waves that are really high, you want to think about potassium. And by that same account, if the T wave is kind of flat, you can think about hypokalemia, but it also could be a sign of coronary ischemia. So, I would say that if you have peak T waves, you definitely want to look at your electrolytes. It's not necessarily 100%, but it's a good, like I said before, ECGs aren't 100%, but they can give you a good clue. So you definitely want to look at electrolytes if you see a peak T wave. So now I'm going to talk a little bit about the QT interval. So the QT interval is this. QT interval is a funky sign because it can indicate issues for sure. The problem is it's not 100%. And the reason why it's not 100% is that the QT interval will change as your heart rate changes. So the faster your heart rate, obviously, the shorter your QT interval. Based on the way the physiology of the heart works. So there's something called QTC, and that's called the QT corrected. There's a couple different equations to come up with the corrected QT, but if someone asks you, the standard equation is to take your QT measured interval and then put it over the square root of your RR. So that's the standard. There's a couple of different equations out there that there's some debate about what's the best equation to use, but in general, if you say this, you won't necessarily be wrong. And so that's the way you talk about so that's the way you talk about your corrected QT. Basically, you want to think about if your QTC is over 450 in men or 470 in women, that's milliseconds, so 450 milliseconds in men or 470 in women, then you want to bring it up. You want to say, hey, their QT looks really high. I'm concerned, that they might have be at risk for some ventricular arrhythmias. A lot of things that can cause that are actual, cardiac medications can actually cause QTC. Usually it's medication associated, but anything over 450, I would say in either gender, I would probably bring it up. Women have a little more room. Just in a clinical sense, a lot of times, especially if they're on a medication that's known to cause QT and it hasn't been a problem, people aren't really concerned unless it gets close to 500. So if you're at 500 milliseconds, if you have a patient who's at 500 milliseconds QTC, you want to bring it up in a patient presentation because it's important. Okay, and I'm briefly going to go over axis here. Axis is just a general way of saying what direction is the depolarization going. And if it's really off, it means your depolarization is going in a weird way and something's going on, like either you have ischemia or who knows. So it's not the most specific way of figuring out what's going on, but it's a way of generally saying, hey, something's really wrong. And the way I learned about how to determine axis is from Dubin, and it's a shorthand. It's not 100%. There's really complicated ways of figuring out a precise axis. I'm just going to give you the really general version of that, and that is you look at leads A, V, F, and 1. And I like to hold up my left and right hands, and my left hand will represent lead 1. My right hand represents AVF, and I'm going to give you 4 different versions of this. So the first version is that the QRS complex is up in both lead 1 and AVF, and that means you have a normal axis. The second one is if you have the axis is up in lead 1, but it's actually down in AVF. So this means there's this waveform in general would be leading more down than it is up. And now there's some cases where it's isoelectric and you could be confusing. Again, this is just a very general way of looking at things. So if it's up in the left and down in the right, well, I would say my left hand is up, so it's left axis deviated. It's the way I think about it is it's leading to the left. So left axis. Sorry, I know my writing's horrible here. Deviation. And now if the opposite is true, and then it's down in the left and up in AVF, well then my right hand is facing up. I have a thumbs up in my right, so that's right axis deviation. And then the last case is if they're both down, and what that is called extreme right axis deviation. And what that means is that there's something real, it's kind of like what they call cardiac no man's land. So you could say extreme right axis deviation. Okay. All right, so I think I actually am going to stop here and just finish up with the last video with the things you want to include in a normal presentation about an ECG and some definitions about normal sinus rhythm.